Well, good morning or afternoon, wherever you happen to be tuned in from. I am Dr. Dan Mingle, founder and CEO of Mingle Analytics. Most of you have met me already in one way or another. Let's dig in here on today's content. There we go. So we'll become, as typical with this series on the final rule, I'll be reviewing first the basics. We're hitting this every time. If nothing else, you're going to come out of this with a solid understanding of the basics, and then we'll hit heavily on advancing care information. I want you to at least be exposed to that and know what's out there. So that's where we are. And let's start here with some notes. Again, many of you have heard this already. Never hurts to remind you once again, PQRS is not yet over. And if you don't submit PQRS 2016, many of you have up to 6% of your Medicare billings to lose. Also a reminder that Medicaid and hospital meaningful use are unchanged by MACRA. So those of you who are participating in these programs, don't stop. Also, a new administration is coming on board. We'll see what the Electoral College has to say about that coming up. But a lot of people are thinking that with the new administration, the MIPS, MACRA, the need for reporting may be gone. But don't. I think it would be dangerous to think that. There are lots of promises to gut and get rid of ACA. But MACRA is not ACA. Whereas our work for you in the past has been governed a lot by ACA, when MACRA was signed into law, that took over. And it's no one's campaign promise to get rid of MACRA. MACRA was bipartisan, a 98-2 vote in Senate to enact this. I don't know that anyone understands MACRA enough to even think to get rid of it. So for all those reasons, expect it to stay in place. Expect it to still be what drives quality payments in the next 5 years anyway. Remember also that the transition year of 2017 looks easy, but there's still a lot of ways to fail, so get professional help, wear your protective gear, make sure your submission is rock solid to avoid the penalty. There's lots of ways to avoid the penalty in this coming year. There's no excuse for anyone to be penalized for the 2017 work. So a quick review, if you know all the basics, I think so. Glance over that. And again, these programs on the left did not disappear. They're being reformatted, rebranded, remixed as the programs on the right. The quality payment program with what Medicare describes as the first pathway of alternative payment models, and the second pathway of the merit-based incentive payment system. Medicare does have a very good informational site. I like how they've built this and present it. They continually update it with new information. They've never been more clear. Not to say that all their communications are clear and concise, but they've never been better than I've seen on this site. So look there for data and don't hesitate to ask us questions. Submit by email. Look at our blog. And again, the essential improvement from the old programs to the new, and I like the new program compared to the old. I think it's dramatically better than the combination of the old programs. One of the things is they've taken all these programs which have been pass-fail, overlaying with each other, conflicting with each other to some extent, and they're combining it, coordinating it under what's called the composite performance score. So all those scores are added together to make one single performance score. And instead of having pass-fail systems that you suddenly fall off a cliff and are subject to big penalties or hopefully big incentives, now it's more of a continuous variable. And so small improvements or worsening of performance correspond to small changes in the adjustment factor. So I think that the dynamics there are enormously better, and no longer can a small well, I guess I can't say that in all honesty. I think there are some single technical problems that could that could invalidate your whole submission. That's far less common now than under the old system. Now that almost each measure stands alone, each performance category, they continue to contribute to this score, whether or not the rest passes or fails. And of course, it's built on, here's the schedule of over a 4-year span. Well, actually, this changes over 3 years, those first 3 years to get to the mature level. 30 points from quality, 30 points from cost, 25 to advancing care information, and 15 to clinical practice improvement activities go into that performance score. In this first year, we're given this year off from cost. All 60 of those points are attributed to quality. So that's and the adjustment factor varies on this schedule, going from plus or minus 4 to 5 to 7 to 9, and with these first 5 years of the program, an additional $500 million kicked in as an exceptional performance bonus. So those are the basics, and again, for the first 2 years, our eligible clinicians under MIPS is not quite the full list who are eligible providers under PQRS. Those on the left were in for PQRS and are still in for MIPS. Those on the right were in for PQRS but out in the first 2 years of MIPS. In the third or the fourth year, we expect them to be brought back in. Of course, there's no requirement that it be brought back in, but it does seem to be Medicare's intention, and we won't know that for sure until they're written into a final rule that they're coming back in. So I would expect that for the 2019 or 2020 performance years that they will be back in. And of course, there's some that are excluded. Your first year ever enrolling in any practice in Medicare, you don't have to submit. If you're a qualifying APM participant, you don't submit to MIPS or you don't participate in MIPS. If you're a partial QP, you can choose to, and clinicians that fall under the low volume threshold don't have to, and that low volume threshold is $30,000 in annual allowable charges or 100 unique patients. Medicare is going to be measuring this over a 2-year period, and if you qualify for the low volume threshold in either of those 2 1-year periods, you're low volume. And you'll know about that by December, by the end of December of the year of measurement, and that measurement period actually spans years, so they have some time to process it and post it. So we've finished the 2015 to 16 measurement year already, and we're into the 2016-17 measurement year. That'll be over by August 31st, and again by December 31st, 2017, you'll know whether low volume in either of those 2 years forgive the MIPS for you. So, and 2017, of course, is judged by Medicare to be the transition year and iterative learning and development period, this graph, the graph for 2017 is very different than the one you saw for subsequent years. And what it means is that it should be very easy for everybody to avoid the penalty. You do anything and you don't get penalized, and anything beyond just the minimal moves you up the positive adjustment scale. And of course, because they collect from the losers and distribute to the winners, because they're making it so easy not to lose, there's less money to distribute amongst the winners. So overall, they don't expect, even with the exceptional performance bonus kicking in, that 4% will be that anyone can earn as much as 4%. It'll probably be capped at around not capped. It'll probably calculate to around 2.5% at the top. So without any further ado, let's get into advancing care information. So again, if you're in hospital or Medicaid meaningful use, those do not change. You still have to report. The one change in those programs, there's no longer a requirement for states to report their meaningful users to Medicare. There's no longer the connection between the two programs. Medicare is entirely over to the to the advancing care information modifications to meaningful use. Medicaid meaningful users 2016 is the last year to be. This year is the last year to begin receiving incentive payments, and it'll be all over by 2021. So the new focus, the dramatic refocusing and improvement, I think, of the meaningful use program, focusing now on implementing and using. Just making sure you've got it in place. Not so much those, they've gotten rid of all the thresholds for what you have to do, and certainly now taken away all those things about clinical care. So no longer is there a, the knowledge support, the clinical information side. It's now focusing on having the EMR in place that's certified, using health information exchange, engaging patients, and coordinating care. Really, those four foci, and rewarding small increments and rewarding even innovative use. That you don't have to meet those thresholds anymore. You can focus on whatever areas make sense for your patients in your practice, in your setting. And they've also changed the focus of reporting. It was NPI based, that is individual practitioner based, and we had to bring in data from past programs or past practices because we were advancing through the stages of meaningful use. We also had to bring in from other practices that each doctor was participating in at that time. Now we're back to the same model we use for PQRS, and that's a TIN NPI. So you're reporting at that practice level, and you don't have to bring in other practice data. Now that means for each individual practitioner, they have a reporting obligation in each practice. But again, I think that's much easier than bringing those multiple practices together into a single, particularly for the larger organizations. The larger you get, the more difficult that was. So those are great things. So moving on here. So again, I want to, they also introduced this group practice reporting option for advancing care information, which is wonderful. When group practice reporting option was introduced for quality, I saw that as more efficient, more effective, more cost effective than the individual method, and have been pushing that for years in quality reporting, and I've never been disappointed about that. There's very few situations in quality reporting, there are some, but very few situations where an individual report is better than a group report. And I think the same is true as I look at advancing care information. A group practice report is far more efficient and effective than the individual reports. And I urge you to lean in that direction. I'm sure we'll find some exceptions where it's better to report individually, but those are going to be rare. And again, that's a big change, a big improvement that we're now reporting at the practice NPI level, not at the NPI level. Now, there are exclusions. There's people who don't have to report advancing care information. There are clinicians who are new to CEHRT, at least those who weren't required to do meaningful use, but are now on the MIPS rolls which has this ACI component. And those are nurse practitioners, physician's assistants, CRNAs, and clinical nurse specialists. So they don't have to report in the first year. They're given a little time off. And it might extend into the second year that they don't have to report. If they report, they get all the benefit or punishment for reporting. The points will be awarded if they make an ACI submission, but if they don't, it'll be reweighted to 0 and the quality points will be increased to 85. Also, hospital-based physicians are in the same boat, and you're considered hospital-based if 75% or more of your charges are in place of service 21, 22, or 23, and I think that's hospital, ambulatory, inpatient, and ER. And again, similar to the low volume threshold, those charges are measured in each of 2 years prior to the submission, and if you qualify as hospital-based in either of those 2 years, then you're a hospital-based physician, and you can. And if you don't submit ACI, you don't get penalized for that. Your quality points get reweighted to 85. If you do submit ACI, then it's scored, and you take your adjustment for that. There are hardship exclusions for ACI, similar to what we've experienced in the past. Insufficient internet, and there's the, if your area doesn't have broadband, you can find that on broadbandmap.gov. If there's extreme or uncontrollable circumstances, flood, famine, locusts, certainly hurricane, whatever, lack of control over availability, lack of face-to-face patient interaction. Now again, don't hesitate to ask questions throughout. Type them into your question box if anything occurs to you. Now the scoring methodology, there's three components. First is a base score, and the base score is simply designed to know that you've implemented CEHRT, and you have certain basic functionalities that you can use, not necessarily that you are using it, but that it's available and it's configured. So that's the purpose of the base score. You don't get any scoring at all for ACI if you don't pass the whole base score, and 50% of your points come from the base score. Then 50% come from your performance score. And that is basically how much are you using, and what components you're using, how much are you using them, and then there's some bonus points that can get tossed in. If you have extra registry data connections, more health information exchange, and if you use your EHR in your practice improvement activities, you get bonus points for that, and we'll review that in a little bit more detail. And scoring is specific to the certification edition, and this I'll give you the schedule in another slide. But here are the ACI bonus points. There's part of your performance scoring is whether or not you connect to the immunization registry. But there's also syndromic surveillance, electronic case reporting, public health, any public health registry, and clinical data registries all qualify. Any one of them qualifies for a 5% bonus. There's only a single 5% bonus. You can't get multiple. You can't get 20 for doing all four. So if you report, yes, I've done that, and it's functional, you get that 5% bonus. Then the improvement activities using CEHRT, basically anything that's, most of the, anything, I've got a list, or there's a list of about 18 activities. I'm not sure yet whether we can advance that, propose others, but certainly those 18 activities, if you include a CEHRT component in that, and they're fairly liberal about how that's done, then you can get another 10% in your ACI bonus score for using CEHRT in these ways to improve your practice. And I'll give you some examples of that. So 10% added for that, potentially. Oh, here they are. There's 18 of them that they post in the final rule. Again, I'm not sure that we can't create more. That will become clearer with time, and as they give their participant-facing advice. For instance, under the expanded practice access subcategory, one of the activities is to provide 24/7 access for patients to providers who have constant access to the record. And if you use your EHR to do that, and these are under the settings of providing patient access, secure messaging, sending a summary of care, or receiving a summary of care, then that qualifies for that 10% extra points. Similarly, population management, if you're doing a episodic care management practice improvement, if you send a summary of care or request or accept a summary of care, or reconcile the clinical information received, then that qualifies for the 10% bonus. And I won't bore you with the rest of this, but that's the principle. I'm using my EHR in a setting of a practice improvement activity, so you get points for both. On the practice improvement activity, they're weighted high to medium. There's only those two weights. You have to have 2 high weight points to qualify for the 100% of your practice improvement activity points, or 4 medium weight activities, or a combination of 1 high and 2 medium. 4 medium there. So anything in that realm qualifies, and then the extra advancing care information points if you use your EHR in that. Okay, so there are 2 sets of criteria for scoring your ACI based on which certification edition you are on. Now, you can be on either 2014 or 2015 certification edition CEHRT in this coming year, 2017. That correlates with the old meaningful use modified stage 2 and stage 3 criteria. By 2018, the rules require you at this point to be on the 2015 certification edition. And I don't think there are many people on 2015 yet, at least as I'm talking to EHRs, they seem to be still working on their functionality on the 2015 edition. So here's what it looks like if you have, as most of you I expect have, that 2014 edition installed. What this says, the objectives that have survived MIPS are there on the left, listed on the left, and the specific measures that track to those objectives are in the measure column. And then the next is the base score column. So these in green, light green or dark green, are required in the base score. Now what you report is way in the last column. So for security risk analysis, you say I did it or didn't. For e-prescribing, you actually give a numerator and denominator. For these others, a numerator and denominator down to immunization registry reporting, which basically says I'm connected or I'm not. So you have to have a yes in the security risk analysis. You have to attest that you have done a security risk analysis. You have to have some non-zero number in e-prescribing. You have to have a non-zero number for providing patient access and a non-zero number for health information exchange, which I think is limited in the 2014 edition to saying I've sent a summary of care record. So as long as those are non-zero, you pass the entire base score. If any of those, you have a no in security risk analysis or a 0 numerator in any of the other 3, you fail and you don't get any of the ACI points. And if you're submitting as a group, if only one of you has done it once, you pass the base score. And of course, the composite of all of your performance goes into the performance score and drives your overall score up. And if we do the 2015 edition, it essentially just, one more thing here, because there are fewer measures here than there are in 2015, they've doubled your weight for 2 of them. Providing patient access actually gives you twice as much score, 20% of your overall score, and as does health information, and the rest get weighted at 10%. Everything's 10% on the 2015 edition, and they've broken health information exchange out into 3 categories. And there's 5 required measures in the base measure, including it's added request accept a summary of care record. So again, you have to hit all of those. Only one of this is, again, the base score is essentially demonstrating that you've installed EHR and you're using it, and you have certain functionality installed. Even though you may not be using it heavily, it's installed and it's available. So they're no longer saying you have to use it in certain ways, but they are saying you have to have it and you have to have it configured to be usable. And then the performance score, you'll notice that there's actually more than 100 points available. Although you're capped, your entire score is 100 points. You're capped at that. So they allow you to focus on whatever areas here make sense to you and your patients, which is, again, great news. I think a tremendous addition. So there are a total of 145 points that can be earned, 50 base points, 15 bonus points, 80 points from 10 points for each of 8 measures in the 2015 edition, 6 measures in the 2014 edition, with 2 of the measures getting 20 points. Total of 145, remembering you're capped at 100, so there's more than you need. And I've got a question from Amber that says, if our EHR changes from edition 2014 to 2015 during the 2017 calendar year, do we get to choose which one we're using? Good question, Amber. And I have to guess on that at the moment. I don't recall any specific guidance in the final rule on that. I may have missed it. I will look that up again. I believe that you will have the choice, but again, we'll have to confirm that. So don't build your budgets around that until we have a confirmation. Oops. Oh, here we are. So we're moving on to so here, to make it real, I'm using the 2014 edition criteria to give you a hypothetical scoring example. So the reported performance is the 4th column over. So this is what we report for you, or you report in some other fashion. You put a yes in the security analysis and those numbers that are listed here. So base score, because you've got a yes in security analysis, you pass. You have a non-zero e-prescribing and electronic patient access. You have a non-zero health information exchange, so you pass all of those. You earn your 50 base points. And then we look at the actual scores, and because providing patient access and health information exchange both are doubled, we take your 20% and turn it into a 4 score. You take your 25% and turn it into a 5 score. Everything else move the decimal 1 point to get your 15 turns into 1.5 and so forth. So we add up all the performance scores and we get a total of 29.6 in your performance scores in that performance column. You've put a yes for doing electronic case reporting. So you get an extra 5% for that, or 5 points for that. And you've used CEHRT in a practice improvement activity, and you get 10 points for that. Now, using CEHRT in more than one practice improvement activity, you still only get 10 points. So you get it for the first one and no others. So you get all of your potential bonus points in this case at 15, and we add it all up to 94.6. So 50 base points plus 29.6 performance points plus 15 bonus points equals 94.6%. Multiply that by the 25 points that are in the composite performance score, gives you a total of 23.65 ACI points in this submission. Oh my, I was looking at the time. I'm really ahead of time here. So we're getting close. Oh. I'm told I've got lots of questions, so that's great. I'd much rather be spending time answering your questions than going through boring slides. They're not boring. Tell me they're not boring. If you were with me last time for quality, in our hypothetical quality measurement, we got 49.9 points. Now I'm plugging in the ACI at 23.65. We still have CPIA to go. Presuming you'll get all your points, that's 15. It brings us up close to a little under 90. We go up to where it intersects the top line, go across, and it looks like you're getting about a 2% incentive for this hypothetical score. So that's how it all works. now you're experts. So the typical data submission flow, how do you get the data from you to Medicare? So your EHR is required to generate these metrics. It's part of certification. So as we're talking to our EHR friends, they're saying, you know, Dan, we're still going to be measuring these. We have to. Certification requirements demand that we measure all these meaningful use objectives, or what will now be ACI objectives. So they will continue to generate those. They'll provide those to you through some kind of a reporting access in their EHR, depending on the EHR, so they give you those metrics. And then you've always been taking those metrics and you've been typing them in to Medicare's portal. And that will still be available, but Medicare is also trying to get all the vendors to have their own methods of submitting the data, so they don't have to receive it. You don't have to perhaps type it in manually. Now, we will provide you with a similar manual entry form, as most other vendors will do. So you can get in and, just like you did for Medicare, put it into our portal. We can use that data to help guide you where you are through plan strategy, integrate your other measures. We will also, by the time we need to submit this, have a spreadsheet option for you to upload. So whatever you download from your system, you should be able to upload to us so we can bring it in. And of course, we have to convert. Most EMRs will not be able to, at least right out of the box, they won't be able to accommodate individual or GPRO. Some may, but Medicare is anticipating that. The difference between an individual and a GPRO submission, of course, one is you remove the identity of the individual provider, and second, in that case, you do have some duplicate patients that some of the measurements you're doing are about patients who see multiple providers in the system, and when you make a GPRO submission, you roll those patients up into one patient, not one for each provider. So Medicare is allowing us to have duplication in the first years, knowing that we're going to get the data from the EHR. They have some algorithms by which we need to roll them up into a single number for the group, and then you'll get judged on that number. So your vendor does the aggregation and formatting, and formats in a way to electronically submit to Medicare. So that's how it all goes. And I don't see any challenges with getting that flowing smoothly by the time it needs to be in. One other thing to think about in the case of EHR, Medicare wants to be sure that you are prepared to participate in monitoring your EHR vendors. So they want to implement an in-the-field surveillance of CEHRT through the eligible clinicians. That's you, the eligible clinicians. So every year there's an attestation they're asking you to make that says you will cooperate if asked. And they'll have some reactive surveillance, which means if someone complains about an EHR and their capabilities, they will research that by reaching out through your practice, perhaps, to understand what the capabilities of that EHR are and make sure they are hitting their certification requirements. And also some randomized surveillance that they'll just be looking at particular EHRs in some kind of a randomized schedule to make sure they are at what they say they are. So we'll keep an eye open for that. So what does it all mean? Performance matters now more than ever before. Our quality tiering programs, the new program was introducing performance, pay for performance to us, but PQRS overall and even EHR was more of a pay for reporting kind program. With the thresholds, EHR was having more of a performance level. But you really need to choose measures that matter in this new world. What we find is that people who chose measures because they were measurable, because they could get the data, because they could submit them and get a qualifying submission, but they weren't measures they particularly cared about. For instance, if you don't give immunizations but you report on flu shots, yeah, that's something you can give, but what we find is your performance isn't going to be as good as someone who's actually deliberately giving flu shots and considers it a failure if they let someone out of the office without one. So choose measures that matter to you. It doesn't make any sense to invest in a measure that doesn't. If you're not going to brag about it to your patients or your referring providers to get those patients to come to you, it really shouldn't be something that you want to measure. Continuously monitor your measure performance. Because that performance level matters, you want to catch a malperforming measure early. It might take time to understand why it's malperforming, how to fix it. So you need early warning of malperforming measures. So, and you need a continuous improvement program, because this is not static. You're competing with your peers for top dollar here, and something that pays a positive adjustment this year might be neutral next year and might be losing the year after that if you stay static. So you need to continuously watch what I call the data value stream, which is everything. It's not just providing the care. You're probably doing a great job, but you also need to document it, document it every time, document it in the same way, document it with structured data, extract the data effectively, translate it effectively, submit it effectively. So there's a lot of places where where that can break down, and you need professional help sometimes to help you understand where that's breaking down. So what new tools to meet those needs? You know, what we've been doing so far has been effective, has been very helpful, and got us deeply into the market. But we need to automate those data connections. A once a year download of data for some of you is just not enough. If you want early warning of measure malperformance, we'll need to automate those so you can get more frequent measurements or earlier warning. Continuous access to metrics with the ability to slice and dice to know where in your organization you need to put your efforts to improve that data flow. Be able to roll up to higher level and drill down to the practice, to the provider, to the patient list behind each of those measures. You need access to comparative data, your own comparative data against your peers. Know where what good performance is. Know where you can learn about good performance. And also know what's good in your system that others can learn from. And we're putting the Muse Collaborative in place to do just that, to be a learning collaborative. And let's see more. I'm going to move ahead to questions because I think that'll be more exciting than covering. Let's see, let me pause. Yeah, there we go. I'm just going to leave it here so you can read that while I get to the questions. Joanne asks, if reporting as a group, wouldn't the NP/PA have to report along with the MDs and DOs? Yes, absolutely. And that goes for the ACI as well. So now, it is possible, we'll have to explore this a little bit, and I'm not sure if it makes any sense to do this, but I believe the rules would allow us to pull the NPs and PAs out of your ACI report should you choose to. And I'm getting a thumbs up on that. I guess part of my staff has already been exploring that issue. So you have a choice. You can leave them in or exclude them from the group report by these 2017 rules. Yeah, and Gay is pointing out that's for ACI only. You can't leave them out of your quality report or your practice improvement. Well, practice improvement is so easy that it hardly makes any difference to include them or exclude them, except that they might be the ones that drive your scoring on that. If our EHR changes, Amber asks, oh no, we already answered that, Amber. Let me try this to see if I have Sarah asking, if we have a group with providers in a clinic and providers who are strictly hospital-based, how do we determine the way to combine or line up data? Do we submit for multiple EMRs? In the hospital side, who would receive credit for the quality metrics if there are multiple providers seeing the same patient? All right. right, so there's a couple of questions embedded in this one. One is, let me answer the second one first. In the hospital side, who would receive credit for quality metrics? In the group, there's a difference between the individual and the group submission here. In the individual submission, each provider who sees the patient gets credit or blame for the performance or malperformance there. So you would expect, so based on your visit, the patient the demographics, the CPT and ICD code, you assign eligible instances to each provider. And they might be the only provider or one of many providers that engaged that patient. And we all get credits for the good performance. And that makes sense. We're working together to provide a certain service to the patient. The fact that we might disagree about that, those are things that we have to deal with as adults. But basically, it all comes down to a successful or an unsuccessful intervention. And performance that is either performance met or not met, or may perhaps an exclusion. So typically the performance is going to be the same for everybody because this is how this encounter turned out, but everyone gets credit. And then the second part of this question, how do you combine or line up data? And there's a couple, so the presumption is that you have in one practice, in one tax ID number practice, you have multiple information systems. And this is the most common. We find it in a lot of different configurations. Sometimes there might be 3 or more electronic medical records in the ambulatory practices in a single tax ID number. But more often we see one in the ambulatory environment and another in the hospital environment. And there's I think 3 ways to approach that. One is the smaller group you can sometimes ignore. And the number of eligible instances they have still leave you within the data completeness range. So even ignoring and for 2017, the data completeness expectation is 50% of your eligible patients or visits you're reporting on. So if you drop a few because you're not including the hospitalists or the hospital-based providers and you're still within 50%, you're good and you don't have to include them. Another way is you just get data from both sides. And our system anyway, we bring your data in from whatever source, even if you manually abstract charts and add that to the data set, we can bring all those data streams together into a single submission. So that's we've built our system to do that. So it's relatively simple to get multiple data streams to flesh out one single report. And the third method, sometimes they don't have access to the data in that second system, or it may even be a paper chart, and you can abstract the data and manually add it to supplement a submission. Of course, you lose the electronic flow bonus points if you do it that way, if you do any manual submissions to engage them, but sometimes the performance improvement might exceed the potential bonus points, so you may still want to do that. I can't think of anything else to flesh that out with, so so Sarah, I trust that answered that question for you. Wanda asks, how would CMS notify providers of hospital-based status? This changes annually for some of our providers. Would there be an eligibility dedicated site? My expectation, Wanda, is that you'll get that in the CMS portal, where you find your QRUR reports, where you find your feedback reports. You're going to find the couple of analyses they promised to do, and that is low volume status and hospital-based status. What else? There's at least one other. I can't. It doesn't come to mind right away, but. And good chance chance you won't. You could find it now, but it really isn't pertinent because they've already finished one measurement year, which ended August 31st of 2016, and we're into the second measurement year, which will end next August, and the data should be available by December. You might be able to find the old, the first year data as anytime now, but it's possible they won't deliver any of it until you need it the end of next year, just before you have to submit for 2017. And if they elect another place to deliver it other than the CMS portal, we'll let you know about that. So Amber asks, oh, Amber already answered that for Amber. So I'm ready for another question. Look, pass them on. Keep them coming. Come on, it's time to stump the chump. Oh, Sarah. I already answered that one. Amber asks, is Mingle a clinical data registry? Yes. And is there any additional required info to report via a clinical data registry versus using a standard qualified registry? No, I'm trying to understand all the permutations of that question. Is there any additional information necessary? You know, the importance, clinical data, qualified clinical data registry, the QCDR, is the name of this construct. And there's a couple of important things to remember about the QCDR. One, it's really not a mature product. It's been around for a couple of years. It hasn't performed well in these first couple of years. We expect to bring it to our usual level of performance. We haven't actually submitted anything under this construct yet. The dynamics are really very similar to qualified registry. The big difference in qualified clinical data registry is that it allows you to bring measures to market without them having to be fully vetted through the usual Medicare processes. So we have measures that we consider the menu measures in PQRS and now in MIPS, and these are all the published measures with published specs, and they're assigned to their submission mechanisms. So there's one set for qualified registries, there's another set for claims, there's another set for EHR, there's yet another set for the web interface, and even when the measures are similar or named the same, the specifications can be different from mechanism to mechanism. And you have to choose from the defined measures. You can't introduce anything else. Medicare has kind of introduced this awkward process of QCDR in order to accelerate new measures coming to market, understanding that a lot of specialties have difficulty finding measures that are pertinent to them. And saying, well, if you get into a QCDR, you can bring your own to market. Now, there's still some vetting requirements, but they are abbreviated, and you can bring them live much more quickly. Now, this year they've added some additional awkwardness in that, you know, what was clear to me when they introduced it is that they're moving away from the principle that they want measures that are comparable across the country. And they want to be able to compare all practices on this set of measures. But now they've introduced this QCDR process where in a small group of providers can use a single measure, and it's not going to be used by anyone else, and therefore they can't compare it. So they're trying a very awkward process this year of demanding that the QCDRs standardize their measures. And of course, they're not understanding that every QCDR wants their own intellectual property, and they sell based on it. So I don't know. But it's clear they like the process. It does have that advantage for groups that they that they can bring measures that make more sense, at least to them, live early. And we are putting it in place just because we know that it's going to serve some of you and may be the only way that some of you get a full measure set. And also believing, I love measures of healthcare delivery, and measurement is more aligned toward disease science, diagnosis and management. And I also like the QCDR measures that cover multiple specialties, whereas most that are coming live are single specialty measures. Not to say I won't create single specialty measures as well, but my goal is for every one of you to have a solid set of measures that are meaningful for you. Now that meaningful is important, I think the QCDR is important. But if we can find measures for you in qualified registry and EHR in the existing standard methods, those are much more secure, much more comparable. We know how your comparisons are going to be and where you'll score. Also, if a very small set of providers are using a narrow set of measures under QCDR, you're only comparing yourselves to each other, so half of you have to be below average. So I'm wondering how that dynamic works to make you succeed. So we're still working on a lot of those. But if you need QCDR, we have the process live to be able to help you with that. Got that one. Got that one. Got that one. Okay, Amber asks, are there exemptions for ACI objectives like immunization registry like there were in MU? And if we are allowed an exemption, do they penalize providers with exemptions? Do we need to do an additional objective to get a better score? Well, yes, there are. Let me start. There are exemptions. I think the same exemptions for immunization as were there before. You can't. Well, you can institute. You can get the same bonus points from any of the other registry connections that you get that you can get from immunization, but you only get the bonus points and you only get them once. I think they're expecting that the redundancy in the scoring takes care of that, that you don't need immunization to get you to a full score, so you'll make up with that elsewhere. Oh, here's they're mentioning clinical data registry. Now that's not necessarily the qualified clinical data registry, but a clinical data registry connection in the new language earns you the bonus points, and that might be a reason to use our clinical data registry. You don't have to submit to PQRS through that to qualify, but you can. But if you're already connecting data to us to do PQRS, you are connected to the qualified data registry, and even though you're doing one of the other submission mechanisms, you'll still earn those bonus points for that connection. So I hope that kind of rambling, Amber. I'm sorry, but I think the answer is again yes. There are exemptions, and they don't really give you you don't earn any points, but you don't get demerits either if you exempt out of immunization, but enough redundant points that it shouldn't be an issue. Sarah asks, what happens if immunization is required, however, is not available in certain states? I think I've already answered that. No, and part of your question, or would a different registry be required? The answer is no, you don't have to go to a different registry. It is not a part of the base score. You do not have to connect to get your base score. And there's lots of other options to flesh out your performance score that if you lack registry, you can make it up elsewhere. And you can't get performance score with any other registry connection, but you can get bonus score for any other registry connection. Paige asks, can you give some examples of using CEHRT in practice improvement activities? Is this related to the clinical improvement activities, which, yes, oh, excuse me, I jumped the gun. You're not all reading this. I'm reading this myself, so I have to read it to you. Can you give some examples, asked Paige, of using CEHRT in practice improvement activities? Is this related to the clinical improvement activities, which is 15% of MIPS? And you've got it, Paige. If you do a clinical practice improvement activity at 15% of MIPS, and you use CEHRT in order to make that activity happen, you get the bonus points for ACI. You get your points for clinical practice improvement activities, but you get bonus points in ACI. So, you know, it's almost anything you can imagine. If it's advanced, there's advanced access, there's population management. So if you're going to institute, let's say, a warfarin management program using CEHRT to identify the patients, to call them back, to track their labs, any of those would potentially be eligible for the bonus points. You can, for open access, if you're going to say, I'm increasing the number of ways my patient can get care, we're going to use secure messaging to provide web-based advice. That would be a potential. Let me leaf back to the others. I didn't go through the all of the details that I'd proposed as now if I can find that slide. Well, let's get this window out of the way a moment. Oh, there it is. Okay, so here, let's jump down to the last one, beneficiary engagement. So use of certified EHR to capture patient-reported outcomes. So, you know, that's almost requiring the use of the EHR. So it sounds like if you do that particular activity, you're always going to be eligible for the EHR bonus, the ACI bonus. So providing patient access or patient-specific education or care coordination through patient engagement, any of those, configuring your EHR to help you achieve that beneficiary engagement objective would qualify you for that. Let's see, care coordination. The activity is implementation of a specialist's of use of specialist reports back to referring clinician or group to close the referral loop. So what we're doing, you know, in my practice, we often made referrals and never knew whether they were completed or not until the patient came back and said, yeah, I saw them. And we called the office and asked for a referral report to be sent. But in this case, we've got a loop that checks it off and says, I need a report back that verifies that the patient was seen. And we're building that into the send a summary of care, request and accept a summary of care, and the clinical information reconciliation, applying any of those or all of those, and maybe something else, I don't know how much leeway Medicare is going to give us on this, would satisfy that care coordination. Let's see, John asks, so a patient, oh, we're at the top of the hour. We're a minute past. Excuse me for taking you over time. I trust those of you with better things to do have already jumped off, but all of you should feel free to do so. As usual, I will linger here to answer questions as long as there's questions to be answered. So thank you again for wonderful questions and your patient indulgence. So without further ado, I will continue through the question list because there's a lot of great questions here. All right, got that one. So John asks, so a patient portal would satisfy the expanded practice access in CPIA. And John, I'm going to have to that level of detail I haven't mastered yet. So I would be reluctant to give you my impression right off the cuff. So I'm going to take that to the books and answer that offline. Okay, I got that one already. Got that one. Got that one. If you're, Karen asks, if you're, what happened? I was looking at that and suddenly I can't see it anymore. There it is. Karen asks, if you report as a group, will individual providers receive feedback specific to them or just specific to the group? Oh boy, there's a lot of complex interactions between the various reporting coming up in MIPS that didn't occur in PQRS. So I can point to the situations where your individual provider will get individual feedback. So there's ACO level reporting or what's becoming APM level reporting. There's group level reporting, that's practice or TIN, and there's individual, that's NPI level reporting. And they inform one another. You're much more free now to move between one and another. And you might create an APM report, but then not succeed as an APM or have the volume necessary to use the APM, and that APM reporting will be distributed to the TINs under it and to the individuals under them. And there are cases where some of the data they use for ACO or for the TIN level might roll up from the individuals who report. So lots of complex interactions. But by and large, if you report as a group, your data is going to be accessible from the group level, but not the individual. If you report as an ACO, your data is accessible as an ACO, but not at the lower levels. So the message here is that there are some exceptions, but really expect that data will remain accessible at the level that it's reported. I think that should be the assumption you go into it with, and learn the exceptions as they become apparent. And we'll lead you to some of those exceptions as we look at your special circumstances. Let's see, we got that one. Lila asks, do encounters at nursing homes get included in reporting on quality or ACI? Good question. Certainly quality, there are quality reports that are applicable to the CPTs and ICDs you will use in a nursing home. Place of service 32 is never called out in any measure that I'm aware of, nor in qualification to submit or not submit. You can get around some of that by carefully choosing your measures and staying away from those, or if you want to report from the nursing home, leaning toward those that have nursing home CPT codes. But an ACI, I don't have the specific familiarity with all of the specs for the ACI measures. ACI measures, just like quality measures, have visit qualifications to them, and if any of those track to the nursing home, I can't tell you off the top of my head. Felicia asks, are they still doing the trial submission, and when is this going to take place? You know, Felicia, I really don't know anything about a trial submission. In our context, we have a test portal or a test system that we can submit a file to make sure it's technically accurate. And of course, when we engage with a client, we have it's a trial until it's successful. We'll send it back and say, can you please correct this or that? But I'm not familiar with the trial program that you're referring to. Happy to answer that question if you want to email me with a reference with with the specifics of that, I might just be overlooking something I'm using different language for. Maria asks, if we have a TIN with 100 or more providers that are going to participate in an advanced APM, if not each individual provider meets the threshold to be considered a qualified QP or partial QP, what would happen, or what would apply to these individuals? Well, a good question, Maria. First, Medicare's first attempt is going to be to qualify the whole group. So they're going to apply the volume statistics to the whole group, and if the whole group qualifies under that APM for volume, everybody qualifies, so you won't have individuals falling out. If the group doesn't qualify, the next step is going to be look at all the APMs you participate in, because as this program advances, you may actually have multiple APMs in which you're advanced APMs in which you're participating, and bringing those all together might swell your participation rate up to a level that the whole group qualifies. So they'll try to again qualify the whole group under that that concatenation. If that fails, then they go to the individuals and say, well, how many of your individuals are QPs, or PQP is the next level, partial qualifying providers. So how many are eligible based on this one advanced APM, and if they don't qualify with volume under that, how about if we pull all the APMs in which they're involved? And actually, in this case, they're going to go beyond the enterprise and the organization. If your provider goes to multiple practices, works in multiple TINs or health systems, they will look at the APMs that practitioner is involved in everywhere and bring those numbers together. So it's really going to be quite complex, and you're going to have some groups qualifying as a group, some individuals qualifying as individuals. So you will have these situations come up. And basically, it'll take whatever metrics were submitted at the APM level and apply those to all the individuals, and then allow you to bring in other data from the MIPS reporting, either as individuals or groups, and apply that to those. So everyone will have their unique, potentially unique submission. What a mess! But you know, it makes sense if you're a master of the tax codes. It's getting easier every time, isn't it? I don't think I have anything more to say about that. Let's see, Joanne, since public health reporting is an option in 2017, are required to keep a current public health reporting bridge? Well, you're not required to do anything, because if you drop that, you simply can't make the you can't claim those bonus points. But if you have a functioning public health reporting bridge, and you can show that it's active, then that is what was that? 10 points. I'm forgetting now. How many points does that come out to? Leaf through my slides. It's here somewhere. I think I passed it. There we go. Oh yes, 5%. So that that bridge is worth 5% bonus, whether or not you have the immunization bridge running. Okay. I've got one question left. All right, I've been given permission to answer this one last question. So for those of you hardliners who are still hanging, there's 67 people still here. I'm sorry, what a waste of time. No, hope you found this quite valuable. On slide 31, could you go into a little more detail on how your score is closer to a 2% incentive and not 3%? If the plus or minus is 4, okay, yeah, I can do that. let's first touch, so let me read that more succinctly. Again, I'm assuming you're reading with me, but you're not. On slide 31, asked John, could you go into a little more detail on how your score is closer to a 2% incentive and not 3% if the plus or minus is 4% in 2017? Okay, so the first thing I'm going to do is touch on slide 31. So let's go to slide 31. Oh, somebody said if I just type 31 here, it'll take me there, but I didn't do that. Oh, that's, oh, okay, yeah, that gets me there. Okay, so you took me right to the right slide, so that's great. So the answer is that this black line, as you recall, everything from here to this point here, down to this point here, everything below the zero line, the negative adjustment, has to counterbalance everything here. So by statute, by legislation, this is revenue neutral. And you can only distribute to the winners what you collect from the losers. And that's been the case with PQRS, it's the case with MIPS, and they've made it, and so whatever is distributed here amongst the winners, although that is, as you say, theoretically 4%, that's 4% times some kind of an adjustment factor, 4% X. And that X is determined by how much you collect on the negative side. So these have to balance, and therefore you have to have an X. Now, for instance, in the 2016 payment year, that X, am I remembering it's 16, okay? Yeah, X is 16. So if you were slated to gain 1%, it's actually 16% to distribute everything that's collected from the losers to the winners. In this first year of MIPS, this transition year, they've made it so easy to avoid the penalty that this represents their prediction. Now, this is just a prediction, and I use this chart came directly from Medicare's final rule, and it represents what they predict is going to happen. Now, this is going to be modified by reality, obviously, but if they think so many people will take advantage of the easy wins here to avoid the penalty that not many people will fall into the penalty range, and there will only be enough money to distribute that if you look at these numbers, that the peak distribution is going to be slightly less than 1%. So even though they say you can gain 4%, in reality, this X is going to be, what's that, 0.25. And it's going to bring your number down to at peak to somewhere around 1%. Now this money, this is the exceptional performance money, and again, they're going to be distributing it from the 70th percentile up, and again, I look at this and say their prediction of how that will distribute amongst the winners will bring your maximum up to somewhere around 2.5%. A little bit less than 2.5%. I rounded to 2.5%. So it looks to me like you shouldn't count on earning any more than 2.5% at the top of the scale. But again, it's anybody's guess. It really depends on how the market responds. There's a lot of people who are just not planning to do anything because they think that the president-elect is going to trash this whole system. So, you know, they're going to have some rude awakenings when they lose 4% of their 2019 Medicare book of business. So now I can start, if you want, no, I was going to say I can stop marketing if you want me to, so I can stop getting that word out and you'll stand to gain more. But that's irresponsible. So I'll keep letting people know that they have this money to win or lose. That 4% loss to a small practice is big, and particularly since it can be avoided fairly easily. So that's, I think, going to round things out for today's presentation. Boy, it was fun. Thanks for the great questions. That's what really makes it worth doing from my perspective. And I hope I've been useful. So better get back to work. There's things to be done. And happy holidays to everyone, if that's politically correct enough to say. I'll wish it anyway. Happy holiday season. There, that's safe. It is a holiday season, whatever, even if you're not participating in them. Ta-ta for now.